Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, I'm Jonathan Mallara, a clinical pharmacist in breast medical oncology at the University of Texas and the Anderson Cancer Center in Houston, Texas. I'd like to welcome you to this activity, the Interprofessional Approach to Adverse Event Care for the Patient with High-Risk Hormone Receptor Positive HER2-Negative Breast Cancer. Joining me today for this discussion is Nellie Zafman. She is a lead nurse practitioner in solid tumors, particularly breast and gynecologic malignancies, at the Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Medicine in Baltimore, Maryland. Hi, Nellie.
Hello, thank you.
So, as we jump into this topic, I think it's important for clinical teams to be able to move beyond simply prescribing therapy and move to manage the patient's long-term treatment journey in an effort to effectively reduce recurrence for those patients with high-risk hormone receptor positive HER2-negative early breast cancer. Hopefully, over the next 30 minutes, we'll be able to discuss how an integrated interprofessional approach is vital to survivorship and essential for keeping patients adherent to their potentially curative therapy. So, starting off, Nellie, would you be able to tell us a little bit about your care team and the roles that they have with regard to adverse effect management?
In order to help the patient to successfully complete planned therapy, I think it is very important to have an initial discussion with the patient about incorporating CDK4 agents into adjuvant therapy at the time of the first consultation with the patient, when the adjuvant therapy for breast cancer is discussed. We generally have that discussion and develop the pathway for the patient at the time of the initial visit. This is when the patient will discuss anti-estrogen therapy in combination with CDK4 inhibitor. This is when we discuss the duration therapy as well. Once the patient is ready to start, the patient is scheduled to meet with an APP to review medication regimen, side effect monitoring, symptoms to report, contact numbers, when to call the providers. The request for the medication, blood work, EKG if needed, is placed at that time. We discuss the points when the testing needs to take place. In our practice, we're using AMR requests. Once we enter the request, the alert will automatically go to pre-authorization team as well as our specialty pharmacist. Once the medication is approved, the pharmacist will then contact the patient, will go over the side effects, monitoring symptoms to report to check if the patient has any additional questions, and the pharmacist will then document that the first day of the first cycle. And that will be the important point that every member of the team can refer to. The pharmacist will then touch base with the patient in 1 to 2 weeks to assure tolerance of the medication. Our pharmacist will then track blood work results, EKG results if needed, for the first several cycles or until the results stabilize and no additional dose adjustments are needed. We'll assure that the patient also has the provider visit scheduled, usually in 4 weeks or sooner if needed. If the patient has additional questions in between those phone calls or those touch points, they are able to contact our triage nurses as well as our clinic practice nurse who is working closely with the provider. I think it's very important to acknowledge that a team approach is needed to help the patients to successfully complete therapy and assure the tolerance with good quality of life. John, how does patient education monitoring and check-in works in your care team?
Yeah, so somewhat similar to kind of what you were saying, I think on our team, everybody plays a role in the general cascade of patient care. It starts with the physician and or the nurse practitioner on our team providing a broad overview of the medications that they'll be receiving, usually at the very beginning, and then kind of reiterating those points as they get closer or we're transitioning to a new treatment. And so when we're talking about these adjuvant medications, um, I'll go in and I'll try to educate the patient in more depth from the dosing schedule, um, and prescribing or dispensing of the medication to talking about the toxicity and monitoring schedule. And so I'm a bit more integrated in the clinic itself and providing direct education to patients, but I'll help facilitate the dispensing of the medication, kind of as you mentioned, with the specialty pharmacist down in the specialty pharmacy. You know, with regards to those touch points or kind of interim check-ins, we have some systems in place where the nurse will follow up through the electronic health record to establish when the patient is starting their medication. They'll reach out, have the patient confirm their start date, and then we will make sure to update their schedule accordingly for those monitoring labs, CBC, CMP, EKG if required. And then we'll also do some phone check ins. It's a new initiative that we're working on in our clinic to have the pharmacists reach out and provide some reinforcement or, kind of ease some of the concerns that the patient may be having with a variety of the landscape of toxicities. And should the patient report any possible adverse effects, we'll make sure to bring it to the team for planning. So we try not to leave it on any one person's shoulders. If the team member feels comfortable and under the guidance of the physician, we'll make those interventions. But otherwise, it usually uh, comes back to us as a team in clinic, or coordinating through email or phone calls to make sure that the patient's needs are addressed. Across the class, we can see a variety of toxicities. We know that both FDA approved agents, abemaciclib and ribociclib, can cause some neutropenia, hepatotoxicity, and interstitial lung disease and pneumonitis. Looking at abemaciclib, we have risks of VTE or DVT, so deep vein thrombosis, or pulmonary embolism can also occur. And then with ribociclib, we have potential EKG changes or QTC prolongation. And then in rarer instances, we can have some severe cutaneous reactions, so more significant um, skin rashes, Steven Johnson syndromes, and things like that. Abemaciclib is probably more known for risks of diarrhea in patients with gastrointestinal issues, and so um, considering that as a potential barrier for maintaining therapy on this medication, where conversely the ribociclib patients are experiencing more neutropenia. So even though they have built-in off weeks, maybe experiencing more disruptions in their care because of the decrease in their neutrophil count. There's some less prominent toxicities that are still worth mentioning that can occur with either agent. We can potentially see some nausea and vomiting with either of these drugs, as well as some risk for stomatitis or ulcerative um, mouth sores, fatigue, headache, rash, some of those non-specific type of side effects that patients can report. And then when we're checking those labs that you kind of mentioned, we can see abnormalities, um, not only in the neutrophils, but both of these agents can actually cause some artificial elevation in their serum creatinine. It's not really impacting their kidney function, but it's always an interesting point when a provider comes to me and says, "Hey, I see that their serum creatinine is bumped. Are you concerned about this at all?" And depending on the value or how much it's changed, usually it's like a zero point 0.2 to zero point 0.3 milligram per deciliter rise. Um, we may or may not be as concerned. It's more common with abemaciclib, but it can be seen with both agents. And then really, making sure that we're checking the liver function labs for these patients. About one third to one half of patients on either agent will see an increase in their hepatic transaminases. But thankfully, overall, there's a kind of a low risk or incidence of grade 3 transaminitis. Nellie, in your practice, or what are the most common adverse effects that you're seeing in clinic? And to patients, what would be the most concerning?
John, I think in the clinic, we're seeing exactly those side effects that you had presented. And this is really depending on what medication the patient is taking in the adjuvant setting. Those patients who take abemaciclib, they very often have to deal with diarrhea. And in the case of the diarrhea, it is important to discuss management of the diarrhea as well as management of potential dehydration that could be associated with diarrhea. And this is even more of a concern for those patients who have additional comorbidities. Um, if the patient is taking ribociclib, it is important to obtain baseline EKG and then repeat it again in 2 weeks to evaluate for development of QTC interval prolongation. Although realizing that this change happens very infrequently. We also see blood work changes, including neutropenia, as well as changes in the liver function test. And those are exactly the side effects that you had mentioned were present in the trials. To look at the changes and monitoring that is important. Once the patient starts the medication, the close monitoring will be important to assure successful completion of the planned treatment. And we can look at the recommended monitoring. On Monarchy trial, blood work, including CBC and comprehensive panel monitoring every 2 weeks for 2 months initially, and then monthly from months 3 to 6, and then every 3 months until 2 years of therapy. On the Natalie trial, EKG monitoring for QTC interval prolongation at baseline, as well as in 2 weeks after initiation of therapy. CBC and comprehensive panel monitoring every 2 weeks for 2 cycles, and then again monthly, cycle 3 through 6, and then every 3 months for 3 years was recommended. John, how does a pharmacist get involved in patient monitoring in your clinic? Are there any red flags that the patient is having trouble with their medications?
Yeah, so I think a clinical pharmacist can have a role from the very beginning, and then throughout the process. But even before initiation of any therapies, we can help select the most appropriate drug. Kind of breaking down those toxicities that I mentioned before. If a patient has um, specific factors such as comorbid conditions, they have drug-drug interactions that would be concerning. Notably, ribociclib is a moderate CYP3A4 inhibitor, and so that's something that will pop up as a warning within our electronic health record, and there's a lot of questions about that. So being able to be proactive and kind of assess that in real time or before we, commit to a medication can be helpful. And then also making sure that we're considering patient lifestyle, which can impact adherence. I find myself often reviewing the labs for patients. It is something that I, want to make sure I'm keeping tabs on. It's part of our follow up process for patients, and so assisting with the lab review or grading the toxicity in some capacity, making sure that their monitoring schedule is accurate. Should they have any delays in getting the medication? So all of that to just kind of keep things streamlined for the patient on this journey. It's going to be a 2-3 year process depending on the medication. So we want to make sure that we're keeping them, on that path forward. So having a role within the middle of a cycle, at the start of a new cycle, or before they even begin medication altogether, we can have a role. To kind of answer your question about red flags, um, it really kind of depends on what the patient's reporting. We try to really advocate for an open dialogue, good lines of communication because with these oral outpatient medications, we're only going to be seeing them at various intervals, and so it's important for them to know what to report to us, but then also you know bring it to the table, bring it to us at any particular visit. um, I like to make sure that I'm looking at the labs as mentioned, if there is any kind of abnormality or trend, making sure that we're, providing closer attention to it. If they're, jumping right from baseline of no issues to a grade 2 toxicity, well, maybe we need to do a dose reduction or something of that nature, even a little ahead of the game. If the patient reports that they're having inconsistent cycle starts or stopping, are they having difficulty remembering the medication or feeling comfortable taking it? Are they mixing up some of their possible side effect concerns with their endocrine therapy that they're also taking? We find that a lot where they're combining medications and sometimes they're attributing it to one thing versus another. With regards to, difficulty in managing these patients or hurdles or roadblocks, Nelly, how does your team handle patients that are having a difficult time on their therapy?
Every patient is different, and some patients have excellent tolerance to the medication. At the same time, you're right, some of the patients having more difficult time tolerating the medication. Educating the patient about the side effects of the medication, as well as monitoring and potential management, is paramount. And it will assure ultimate adherence to the medication regimen and completion of the planned therapy. But let's look at each medication individually. As we discussed, abemaciclib could be associated with significant diarrhea. Helping the patient to manage diarrhea is very important. In our practice, we treat a lot of young women who have to continue working, take care of the children. They have busy lives, and adequate management will allow them to continue the medication without interruptions. What are the methods to help them to control the diarrhea? Taking diarrheal agents on as needed basis, or even we talk to the patients about taking antidiarrheals preemptively. Dietary changes will be important, as well as hydration will be important. Um, if those measures are not successful, the next step is a dose reduction. Potential dose reduction could be anxiety creating event for some patients. This is also something that we discuss at the initial visit with the patient to allow the patient to be comfortable with the measure. We tell them that if you do have side effects, we will help you to control them, but in some cases, we have to reduce the dose. Multiple explanatory analysis assessing the impact of dose reduction on efficacy reached the same conclusion, confirming that the benefit of abemaciclib is consistent whether the patient took the full dose at 150 milligrams BID twice a day or reduced dose to 100 milligram or 50 milligram dose. And I think discussing those analysis with the patient will allow them to be comfortable with the dose reduction in the situation that it's needed. Alternatively, there are also results of the TRADE study, which is a prospective study. It was phase 2 small study that looked at 90% of the patients, and it looked at a possibility of escalating the dose of abemaciclib. The patients took for 2 weeks 50 milligrams twice a day, then for 2 weeks 100 milligrams twice a day, and after 1 month were able to take 150 milligrams twice a day. And those patients who had no significant side effects associated with the treatment were able to escalate. Close to 70% of the patients were able to reach the full dose of the medication and maintain the full dose at 12 weeks, comparing to 60% of the patients on Monarchy trial. So this is a alternative possible option for some of the patients. Now let's look at the side effects associated with ribociclib and management of those side effects. Considering the fact that the neutropenia was the most common side effect associated with the treatment, on the trial, neutropenia was seen in about 62 to 63% of the patients. In that case, very careful blood work monitoring will need to be necessary. The treatment is paused in the event the neutrophil count falls below 1,000. Cell count will then be repeated in 1 week. Once neutrophil count is above 1,000, ribociclib can be resumed, initially at the same dose. If neutrophil count continues to drop below 1,000, once again, the dose reduction is being considered. Grade 2 liver function elevation, if it is persistent, then dose interruption is necessary. Then hopefully the liver function test recovers back to grade 1, and that's when the ribociclib dose can be resumed at a reduced dose. Grade 3 to 4 liver function test elevation. It's when ALT and AST more than 5% of normal limit. Treatment interruption is indicated if recovery occurs. Resuming at a lower dose or permanently discontinuing ribociclib may be necessary. John, how does this side effect management impact patient care? How can the care team better support the patient to stay on their therapy?
Well, it's a difficult question or a profound question because making sure that we manage these adverse effects can definitely impact patient care. We've been talking about adherence, we've been talking about dose adjustments. Um, I'm always been a fan of the quote, "An ounce of prevention is worth a pound of cure." And so I think it's really important for us to um, try to stay ahead of potential adverse effects, making sure that patients are well educated and knowledgeable about the appropriate and you know supportive medications that they can be taking, supplying them with prescriptions if necessary for antidiarrheals, antiemetics, counseling on those diet and lifestyle changes, like you mentioned earlier. It can really empower the patient to remain compliant and feel comfortable and confident that they can implement those changes when they're necessary. In regards to making sure that patients stay on their therapy, I've talked a little bit about implementing like our phone clinic, which is mostly at the start of a patient's therapy, because that's when we're going to likely see the most benefit of intervention. They're going to likely be seeing diarrhea with abemaciclib pretty quickly. They're likely going to be seeing changes in their lab values with either of these drugs in the first 1 to 2 cycles. But otherwise, making sure that we keep those lines of communication open, as mentioned before, trying to answer any questions honestly, openly, and referring back to the provider team whenever something critical or requiring acute intervention is brought to our attention. Um, I think there's a couple of key takeaways that we can probably drive home during this discussion. And so um, I think it's probably obvious to everyone that if patients are able to remain on their therapy, it allows for better patient outcomes. Um, we can explore alternate dosing strategies to allow patients to remain on therapy. It's very interesting that ribociclib can be initiated at a lower dose in the adjuvant setting for patients. And then with this trade trial, we can maybe work to maintain adherence with abemaciclib a bit better by rather than dose reducing, we can dose escalate, and then making sure that when we're looking at treating these patients, that they're all individuals, that we're making sure that we don't assume any that one CDK4/6 inhibitor is going to fit all. The approach needs to be tailored to each patient as they come into our clinic and express their needs and wants. But Nelly, I'd really like to thank you for this excellent discussion. It's been a lot of fun talking with you and getting to hear a little bit about your practice. And I'd really like to thank you, the audience, for participating in this activity. Please continue on to answer the questions, then follow and complete the survey.